Can you open your mic and your camera? Right.
All right.
All
Yes.
right.
Thank you so much, Lucky.
Yes. Yeah, today we're gonna learn a lot about the how to diagnose and treat the pain from you. Yeah, we have maybe 1 hour for you to present about your thought about how to diagnose pain and treat the pain. Okay, the time is yours.
All right. Thank you very much. Fantastic. I will set up my screen and then we'll get going.
All right. Okay. We started the screen. All right. Yeah, we can see the
Yep.
screen
You can
clearly.
see me okay?
All right.
All right. Perfect. Okay. So then we will get started. So as we're going through, if anybody does have any questions, you can write them in the chat and we'll cover all of them at the end. All right. So as Lucky mentioned, today we are talking about how to diagnose and treat pain. So this is an updated approach to orthopedic care. So my name is Dr. Gene Ketselman, as Lucky had said. I'm a doctor of physical therapy in the United States. I'm a certified strength and conditioning specialist and fellow of the American Academy of Orthopedic Manual Physical Therapists. I'm also the owner of Convergent Movement and Performance, which is an outpatient orthopedic physical therapy clinic in the United States. And I specifically specialize in kind of two groupings of patients. So the first is chronic and persistent pain. So individuals with pain that have been that are more complex in nature and have been going on for many years. And I also work with many athletes and active individuals. So specifically in strength sports and functional fitness-based sports, combat sports, and competitive gymnastics. So those are kind of my big areas of specialization. And I bring all of that up so that I can share that these different kind of diverse populations have many different types of pain. And we're going to speak about those different types of pain and how to work with individuals in those different types of pain. Okay, so the objectives for today's session is to review the need for an updated approach to evaluating and treating neuromusculoskeletal conditions. We're going to introduce a new framework for classifying and treating pain, and we're going to identify key evaluation and treatment considerations based on this new framework. So we'll start out by kind of asking the big question: do we even need an updated approach to diagnosing and treating pain? Is this even necessary, or are we fine with the way that things are right now? So to answer that, let's take a few moments just to reflect. How are we doing treating pain? So in terms of prevalence of pain, at least 10% of the global population, so that's roughly 780 million people, suffer from chronic pain. So that's pain that's been going on beyond the time of normal tissue healing. So in less developed countries, the prevalence can even be as high as 25%. So that's 1 out of every 4 people there have persistent pain. So between 20 and 35% of children and adolescents worldwide experience chronic pain, and commonly linked to conditions such as musculoskeletal pain, headaches, and abdominal pain. These chronic conditions global cause of disability, and diagnoses for the most common chronic pain conditions include things like arthritis, back or neck pain, chronic joint pain, nerve pain, and headaches or migraines. And there's a huge impact of this chronic pain on mental health. So up to 85% of chronic pain patients suffer from severe depression, significantly affecting their quality of life. So if you think about it, that's more than 8 out of 10 patients with chronic pain that are affected by severe depression. And so chronic pain has also been linked to increased suicide rates. So nearly 10.2% of suicides between 2003 and 2014 in the United States involved individuals with chronic pain. So that is an enormous number. We see that there is a huge burden in terms of chronic pain and persistent pain, where even with all of our technology and all of our treatments, pain continues to keep going on beyond what would normally be thought of as kind of normal tissue healing. So what's going on? What are we doing wrong? That's what we need to figure out in order to understand what we can do to try to make things better. So to understand this, let's really take a look at what the gold standard diagnostic approach is currently in our world. And that would be things like imaging, right? So X-rays, MRIs, CAT scans, things like that. We would normally think, well, that's the way that we diagnose pain, right? If somebody has an issue, that's how we'll diagnose what's going on. So the typical traditional way of doing things is, let's say somebody has low back pain. They have back pain, they go to their doctor. They tell their doctor, I have low back pain. So the doctor goes and does an MRI, let's say. So the doctor does the MRI, and the MRI comes back and shows a herniated disc. So of course, naturally, the doctor would say, well, we found a herniated disc. So the cause of your pain is this herniated disc. So we're going to treat the disc herniation, and then you will feel better. Right, so that's the typical approach. I'm sure that sounds very familiar to everybody on this call, right? But the interesting thing is that new research has changed everything that we knew or know about this approach. So in the last 1 to 2 decades, there has been more and more research coming out showing that even those without any pain have the same findings on their MRIs and on their CAT scans and on their X-rays. So to illustrate what I'm trying to say here, let's look at a few examples in the research. So when it comes to the shoulder, MRI studies of adults by the way, have these rotator cuff tears on their MRIs, and they don't even know about it. So if you take somebody over the age of 60 without any pain, 1 out of every 2 individuals will still have this rotator cuff tear. Another study on professional baseball pitchers showed that 40% of them had either partial or full thickness rotator cuff tears, and yet had no pain while playing and remain pain-free even after 5 years after the study. So this isn't just happening in the shoulder. We're going to look at other joints as well. So when it comes to the hip, there's only a weak association between joint space narrowing seen on hip X-rays and actual symptoms. So joint space narrowing typically being things like arthritic conditions. MRIs of asymptomatic participants, so again, individuals without any pain, between the ages of 15 and 66 years old, revealed abnormalities in 73% of hips, with labral tears being identified in 69% of those joints. Another study showed that 77% of healthy hockey players who had no pain had hip and groin abnormalities on their MRIs. And another study looking at a large amount of studies involving a total of 2,114 asymptomatic hips. So again, that many people without any hip pain, concluded that 37% demonstrated cam deformity impingement, 67 demonstrated pincer deformity impingement, and 68% demonstrated a labral injury. For the knee, a research review looking at studies involving a total of 5,397 asymptomatic knees, so knees without any pain, concluded that in those over the age of 40, 19 to 43% had osteoarthritis, 43% had cartilage defects, and 19% had meniscal tears. And in those under the age of 40, 4 to 14% had arthritis, 11% had cartilage defects, and 4% had meniscal tears. And finally, with the foot, although there is an association with plantar fasciitis and heel spurs, the research has shown that 32% of people with no foot or heel pain also have those same heel spurs visible on X-ray. All right, so these are just a few examples. There are many, many, many more studies that in all the different joints that show this over and over and over again, that you can be completely pain-free and have these abnormal imaging findings, meaning the imaging findings themselves do not necessarily correlate or are associated with somebody's pain. Somebody can have these imaging findings and can be pain-free. Somebody can have these imaging findings and have pain, but it's possible that that pain is coming from something other than those imaging findings, because those imaging findings can be pain-free. So one more, actually, I apologize. I forgot there's one more that we're going to talk about, spine, and this is an interesting one. So if you take people without pain and put them through an MRI, you get some surprising results. In one research experiment, over 70% of people in their 20s had disc bulges in their neck, and none had pain. And another research study looking at MRIs of people that didn't have any back pain found that 37% of 20-year-olds, 80% of 50-year-olds, 96% of 80-year-olds all had disc degeneration. And 30% of 20-year-olds, 60% of 50-year-olds, and 84% of 80-year-olds have disc bulging. So it turns out, as I just spoke about, that some of these changes are simply a normal part of the aging process and do not necessarily correlate with pain. All right. So the International Association for the Study of Pain concluded that low back pain is not usually associated with a specific identifiable pathoanatomical cause. So let me say that again. Low back pain is not usually associated with something that shows up on your imaging, all right? 85 to 95% of people presenting to primary care providers do not have a specific identifiable pathoanatomical origin for their pain. That is an enormous percentage. So overall, what does the research have to say? Tissue damage does not always cause pain. Sometimes it does, and sometimes it doesn't. And so the big question that may be coming up on your mind at this point is, so then what do I treat? If we see imaging results and we don't actually know if that correlates with pain or not, if it has anything to do with their pain or not, then as a therapist, what am I going to treat? And so that's what we're going to talk about here, a more effective alternative, which is to treat based on what is now known as pain phenotypes. So when it comes to this pain phenotype model, we classify a patient's condition based on their pain phenotype rather than a tissue source. A pain phenotype refers to a distinct category or pattern of pain that emerges based on the underlying mechanisms, causes, and characteristics of an individual's pain experience. So it helps us determine why they have the pain. These phenotypes help clinicians better understand, diagnose, and treat pain by tailoring interventions to the specific type of pain a person is experiencing. It considers biological, psychological, and social factors, so not just what shows up on the imaging. If this isn't quite making sense yet, I promise you I'm going to make this very clear and we're all going to understand what this means. So in other words, what we're saying is it's time to classify the pain, not the damage. The MRIs, the CAT scans, the X-rays, all the imaging testing, that classifies damage. It puts a label on what damage we have in our tissues. But again, that doesn't necessarily correlate with pain. So we are going to classify the pain now. So to classify the pain, we must understand the purpose of the pain. So first, pain is normal, and it's a necessary aspect for survival. It's a necessary thing for survival. Without pain, we would not be able to survive. There are certain medical conditions where individuals are not able to feel pain, and they generally do not have a full lifespan. Pain is transmitted and experienced through the nervous system. So signals and information are picked up by sensors in the body. These sensors are what are typically known as nociceptors. And they typically pick up information around thermal, so temperature, heat, cold, things like that. Chemical, so things that might be running through our bloodstream. Inflammatory markers would be an example of chemical. And finally, mechanical. So this is where movements, postures, loads play an impact. All right, so that's what nociceptors pick up. But they only pick up that information. Nociceptors do not actually pick up pain. They just pick up that information. Then they send that information to the brain, and pain is always, 100% of the time, no matter what, created in the brain itself or in the central nervous system. So the brain will create pain when it consciously or unconsciously believes that it is not safe. So if there is a potential threat in any way to that individual, pain can be created. So pain is created to protect us from the potential threat. It is telling us to pay attention and get help. So somebody may have a fractured bone, and the brain realizes this is important, this is a threat to our bodies, so we're going to create pain. So the fracture itself does not create pain. It's the brain's interpretation of what's going on that will create pain because it feels threatened. All right, so although the nervous system becomes more sensitive to pain due to threat, this sensitivity should gradually decrease as safety is reestablished. So somebody has a fracture, the brain realizes this is dangerous, we need help, so I'm going to create an enormous amount of pain. As that fracture begins to heal, the brain is beginning to realize, all right, this is less threatening because it is healing, and so the pain will gradually go down. That's how it works with sprains, with strains, with any kind of actual physical injury. The brain senses pain. The brain senses a threat. It creates pain. As tissue is healing, the brain is realizing less threat because it is healing, so it will create less pain. All right, so then chronic pain, so pain that continues on longer than normal tissue healing, is when the nervous system remains very sensitive. And the sensitivity doesn't come down. So even though the tissue is healing, the brain still feels like there is a threat. That is why pain persists for longer than normal healing. So if you've ever worked with a patient and you're thinking, well, this should have healed a while ago, or why is this person still having pain? They sprained their ankle and it's 2 years later, it should have healed. Because for whatever reason, the brain still feels threatened. So the brain perceives a persistent threat that is not decreasing. And the longer the threat persists, the more sensitive the nervous system becomes and the longer the pain remains. So you always want to remember, the pain is real and it is not made up or imaginary. So if somebody is having pain 5 years later after an ankle sprain, please don't think that their pain is fake. They're imagining it, they're making it up. The pain is real. It might just not be because of the actual ankle sprain. So the ultimate goal of treating pain is to reestablish a sense of safety. Whether it's an acute injury or chronic pain, the whole goal is to reestablish safety. But knowing how specifically intervention, or knowing which specific interventions to apply in order to reestablish a sense of safety depends on how specifically the patient's brain is using pain to protect them. So in other words, this is the purpose of pain phenotyping. It's to classify how specifically the patient's brain is feeling threatened, which allows us to know what to do about it. So the International Association for the Study of Pain has officially identified and defined 3 primary phenotypes of pain. There is nociceptive pain, neuropathic pain, and nociplastic pain. So when it comes to nociceptive pain, this is pain arising from tissue damage. So remember, we talked about the primary categories of nociceptors: thermal, chemical, and mechanical. So if there is information coming from those nociceptors and the brain feels threatened, that is that nociceptive pain. The primary threat in these patients is within the body. So the threat to the brain is within the body. Then we have neuropathic pain. This is pain that is caused by nerve damage or nerve-related dysfunctions. So the primary threat here is within the nerves. And then finally, the big one, this is the one that is the most recent introduction, and the one that is really being, that is more new to individuals and that we really need to take the time to learn well, is nociplastic pain. This is pain that arises from altered nociception, despite no clear evidence of actual or threatened tissue damage, meaning the brain is interpreting pain from nociceptors even though there is no actual issue within the body. So here, the primary threat is within the brain. The brain itself is behind the threat. And we're going to talk about what that means. All right, so it's again these 3 phenotypes: nociceptive, which is the threat from the body; neuropathic, which is the threat from nerves; and nociplastic, which is the threat from the brain. So we're going to take the time now to briefly go through each one of these 3 phenotypes. And we're going to talk about the subjective and objective parts of the assessment of what you may see with each one of these 3 phenotypes, so that you can begin to start trying to understand how to classify these patients. And then we'll briefly speak on treatment approaches for each one of these 3 phenotypes. All right, so we begin with nociceptive pain. So the threat is from the body. So with nociceptive pain, it is pain that results from the activation of nociceptors, appropriate activation of nociceptors, due to actual or threatened damage to non-neural tissue. Okay? So this is tissue within our body that does not involve the nerves, because when it involves the nerves, we'll talk about neuropathic. So this involves a normal response to noxious stimuli, such as chemical, mechanical, and thermal. So for characteristics, they're going to have localized pain. It may be referred, but still traceable to a specific tissue source. So examples of nociceptive pain are those that you typically think about with injury. So your classical type of injuries. So we have inflammatory-based conditions. So these could be your inflammatory arthritis conditions, whether that's osteoarthritis that is inflammation-based, but also things like rheumatoid arthritis, psoriatic arthritis. It could be other inflammatory conditions like ankylosing spondylitis. So all of these types of inflammatory-based conditions. We also have conditions that involve tissue overload or damage. So these are your fractures, your sprains, your strains, your tendinopathies, your labral or meniscus or disc tears, your cartilage damage, right? So your typical traditional injuries. And also just your run-of-the-mill overuse injuries or excessive loading without appropriate recovering. So an individual goes out and plays a sport over the week, or works out really hard in the gym, and now they are just very sore. So overuse or excessive loading and they haven't fully recovered yet. So those types of conditions, those are your classical nociceptive pain conditions. So what will you see in the what will you hear actually in the subjective exam? So first, in terms of where the pain is going to be located, the pain, they're going to complain of pain that is localized to the area of the injury or dysfunction, with possible somatic referral, but it's not widespread. So in other words, if they have, let's say, rotator cuff issues, right, a supraspinatus tendinopathy or supraspinatus tear, they'll have shoulder pain, and it may possibly refer down to the elbow because that is a common referral pattern for the rotator cuff. But otherwise, it's going to be in that area. It's going to hurt around the area of the injury. In terms of onset and pattern, the pain is typically going to be linked to a physical trauma, pathological process that may involve inflammation, or a movement or postural dysfunction. In terms of characteristics, they may be associated with signs of inflammation. So those inflammatory signs can be constant pain, swelling, redness, heat. But they could also be intermittent and sharp with movement. So they could be intermittent and sharp that typically is associated with certain movements or other kinds of mechanical provocation. So in terms of aggravating and easing factors, the pain has a clear and proportionate mechanical or anatomical pattern, often related to postures, movements, loads, or specific activities. In other words, it makes sense. So if somebody has, let's say, facet syndrome in their low back, right? So lumbar spine facet syndrome. Well, we know that extension activities, lumbar extension, is what is going to load the facets, while lumbar flexion may unload the facets. So in nociceptive pain, it's going to be very consistent. It's going to be, the patient's going to say, every time I bend backwards, it hurts. But if I bend forward or if I don't bend backwards, it doesn't hurt. So it's a very clear pattern. That is a typical nociceptive pain condition. In terms of neurological symptoms, there's going to be no neurological symptoms. We'll talk about neurological symptoms, but that's going to be your neuropathic conditions. For psychosocial factors, maladaptive psychosocial factors, in other words, meaning negative emotions or poor self-efficacy, are typically absent or not significantly contributing. So you will not typically see things like anxiety, depression, panic attacks, things like that that are associated with this kind of pain. For medications, they're going to respond well to non-steroidal anti-inflammatory drugs, steroidal anti-inflammatory drugs, as well as simple analgesics. And for healing and resolution, their pain will resolve in line with expected tissue healing rates and pathology recovery. These are your classical proliferation phase, remodeling phase, and it takes the normal tissue healing pattern. Okay? So for objectives, what will you see when you're testing these individuals? So when it comes to mechanical and anatomical pain patterns, their pain is very clear, like we mentioned before, it's consistent and very proportionate to movement or mechanical testing. So it happens very consistently when you specifically load the injured tissue. It's going to be localized pain, like what we talked about before. The pain is confined to the specific area of the injury. They may potentially have inflammatory signs if it's an inflammatory condition or in the inflammatory phase of healing. So they may have the presence of swelling, redness, or heat. There's going to be no neurological involvement. So myotomes, dermatomes, neural tension testing are all normal, and no maladaptive pain behaviors. So behavior and movement patterns are consistent with injury, and they do not indicate exaggerated or psychological pain responses. So how do we treat these nociceptive pain conditions? So the good thing is these are your classical textbook types of pain conditions. This is what we normally learn about in school and continuing education courses. So if the pain has an inflammatory condition, you're going to treat the inflammation, right? You're going to either, whether it be medications or nutritional strategies or movement strategies, but the point is your whole goal is to reduce the inflammation. For tissue overload or damage conditions, you want to promote tissue healing and remodeling. So modalities in manual therapy can be as needed to promote the healing process. In our manual therapy program, we will teach all about the different manual therapy approaches for this nociceptive pain classification. And for exercise, the whole goal of exercise in this nociceptive conditions is to initially unload the injured tissue, but then progressively reload the tissue based on the healing phases. So as we talked about, there's inflammatory, proliferation, remodeling, healing phases, and based on which phase you are in will determine what kind of loading you are doing. Okay. Then finally, you're going to correct mobility, stability, motor control, strength, endurance, and biomechanical imbalances. That's where all of those factors that we've typically learned about come into play. So again, manual therapy, in our manual therapy program, we will teach all about how to improve, especially mobility factors here. But there are also manual therapy techniques that can help for things like motor control. And then exercise is also used for all of these factors as well. All right, so that is how you will tackle these nociceptive pain conditions. So next, we move on to neuropathic pain conditions. All right. So for neuropathic pain, this is pain that is caused by a lesion or disease or initially injury affecting the peripheral somatosensory nervous system. So it involves abnormal processing of pain signals by the nervous system, often due to nerve damage or dysfunction. Typically described as numbness, tingling, pins or needles, burning, shooting, or electric-like sensations. So examples that you're going to see in a typical orthopedic practice for neuropathic pain. Things like spinal stenosis, disc herniations with radicular symptoms, spondylolisthesis with radicular symptoms, sciatica, carpal tunnel, and also diabetic neuropathy will fall under neuropathic pain. So even though diabetic neuropathy is not quite an orthopedic condition, it is still a common condition that we see out there in the world, and that would fall under the neuropathic pain phenotype. So what will you hear from these patients that have neuropathic pain? In terms of location of pain, the pain is localized to the area associated with a specific neural tissue. So this is where you want to consider dermatomal or cutaneous distributions of nerves. For onset and pattern, they're going to have a history of nerve injury, nerve pathology, or mechanical nerve compromise. So something happened that is impacting the nerve. For pain characteristics, they're going to have pain that's described as burning, shooting, sharp, aching, or electric shock-like, or other dysthesias, meaning other unusual nerve-related symptoms like crawling feeling, electrical feeling, heaviness, or even tightness. Many people don't realize that neuropathic pain conditions will often feel tight. So somebody with, let's say, sciatica, they don't always complain of pain down their leg or burning down their leg. They might just say that their whole leg feels tight, or they have this, like it feels like their hamstring is always tight all day long, kind of thing. So tightness is a very common symptom of neuropathic pain. So for aggravating and easing factors, pain again has a clear and proportionate mechanical or anatomical pattern involving activities or postures associated with movement, loading, tension, or compression of a specific neural tissue. So let's take an example, just like how we talked about Facet syndrome in nociceptive pain. Let's say an individual has true lumbar spine stenosis, right? So they have stenosis and it's actually associated with their pain. They're going to have a very predictable pattern again. So with stenosis, we know that when you extend or bend backwards, you're closing the space through which the nerves travel. And so you will have a worsening of symptoms with lumbar extension. But when they flex their spine, when they do lumbar flexion, you're going to open up the neural space, allowing for more space and less compression on the nerve. So a patient with stenotic pain, they're going to say, I can sit all day, I can bend forward, and I feel great. But when I walk for long periods of time or when I bend backwards, that is when my pain comes on. So it's a very predictable pain that is associated with very specific loading of nerve tissue. All right, so then we move on to psychosocial factors. In these conditions, the pain may be associated with psychological distress or mood disturbances. So sometimes it is, sometimes it's not, but you want to be aware that it can be. For medication responses, for more acute cases, they may be responsive to simple non-steroidal anti-inflammatories or also anti-inflammatory steroids, like getting cortisone injections into their spine, things like that. Right? For chronic or more complicated cases, though, when it comes to neuropathic pain, they're actually going to do much better with things like anti-epileptic medications, so Neurontin, Lyrica, or antidepressant medications. So we know that we're not going to be the ones obviously prescribing these medications, but I'm just sharing this information so that you're aware if you're ever working with these patients and you may see that they are taking these medications or they were prescribed these medications by their physician, that you will understand kind of the purpose and why. Okay. So objective measures, what will you see when you're testing these patients? So the pain is going to be triggered by movement or mechanical tests that stress neural tissue. Okay. So the same kind of idea that we talked about with our stenotic patient. If we test lumbar extension, it's going to feel worse. Or if somebody has, let's say, a disc herniation with radicular symptoms and you do your straight leg raise test, that's going to reproduce their symptoms. For neurological findings, they're going to have possible altered reflexes, sensations, so dermatomes, or muscle strength, myotomes, things like that. They're going to have possible autonomic nervous system signs as well in certain situations. So things like trophic changes like skin, hair, or nail abnormalities. That is also a sign of neuropathic. And they're going to have imaging or tests, so things like MRI, CT scans, nerve conduction tests that confirm peripheral neuropathic involvement. So for treatment of these conditions, first you want to see, is the nerve compressed? If it is, the initial goal is to decompress that nerve, because if that nerve remains compressed, all the other treatments will not be effective. If somebody has, let's say, a significant disc herniation that is pressing on a nerve, there is no amount of ultrasound, electric stimulation, or even massage or anything like that that is going to make the condition better. You must decompress that nerve first. Okay. In our program, we will discuss all the different ways, manual therapy wise and otherwise, to decompress nerves within the clinic. Also, then once we are improving the nerve compression, if there is any hypersensitivity, there are approaches to desensitize nerves. So there are treatment methods that help to desensitize. And then finally, for conditions involving impaired nerve mobility and neurodynamics, we will work on nerve mobilizations, so neurodynamic mobilizations. So all in all, that is the approach to treating neuropathic pain. And within our manual therapy certification, we cover techniques, the specifics of how to do these things. And then finally, we have our nociplastic pain. All right, so with nociplastic pain, this is pain that arises from altered nociception despite no clear evidence or actual threatened tissue damage or disease. So these are your ankle sprains that still hurt 3 years later. So this is thought to involve central sensitization, where the central nervous system becomes overly reactive to stimuli. It's often described as widespread, persistent, unpredictable, that's the big key, unpredictable, and may be associated with fatigue, poor sleep, and mood disturbances. So examples of these conditions that you may have seen, number one, fibromyalgia. If you ever work with patients with fibromyalgia, that is classic nociplastic pain. So widespread musculoskeletal pain that's accompanied by fatigue and mood issues. Also, chronic nonspecific low back pain. So persistent back pain without a clear anatomical cause. So these are your back pain patients where just everything hurts. They've been having pain for 3 years, 5 years, 10 years, 20 years, and there's no pattern. It's not associated with one specific thing. It's just everything hurts. Or it's completely unpredictable. Sometimes it hurts, sometimes it doesn't, and we're not really sure what's going on. Another condition that we don't necessarily treat, but just so you're aware, irritable bowel syndrome. So if you ever work with patients and in their medical history form, you see it written down, irritable bowel syndrome, that is a sign of potential nociplastic pain. So this is chronic abdominal pain without identifiable structural abnormalities. And finally, another very well-known one is complex regional pain syndrome. So these are very complicated, complex patients that are traditionally very difficult to treat. However, if you truly understand nociplastic pain, you will have the tools and understanding of how to treat these conditions. So this complex regional pain syndrome is a mixed condition, meaning that it also involves neuropathic, the neuropathic phenotype. So with complex regional pain syndrome, they are a mix of nociplastic and neuropathic. So for the subjective of this nociplastic pain, they're going to have widespread or multifocal pain, often disproportionate to the observed tissue or nerve damage. So they're going to have pain that does not quite make sense with what imaging shows, or what the injury sounds like, or what it sounds like the injury was. It's going to be difficult to pinpoint a clear cause of the pain, and the pain may be intermittent, constant, or unremitting in nature. It's often associated with issues like fatigue, sleep disturbances, cognitive difficulties, so even things like memory problems, and emotional challenges such as anxiety and depression. So if your patient has these things, definitely be considering the possibility of nociplastic pain. So in terms of, or I'm sorry, one second. Yes. So the pain may occur independently. So the nociplastic pain may just be the cause of their pain themselves, so fibromyalgia, tension type headaches, or it can be mixed. So how we talked about with complex regional pain syndrome, that can be mixed between nociplastic and neuropathic. For treatment, pain is frequently unresponsive to traditional treatments. So your patients may be saying, I've tried therapy many, many times. I've had this for a decade. I've tried all these different approaches and nothing has been working. When you hear that, that is another sign of potential nociplastic pain. And it's typically associated with significant functional and emotional disruption, including mood changes and heightened sensory disturbances. So there is a criteria that has been laid out for how to identify these nociplastic pain conditions. So there are 4 different categories that you want to consider with nociplastic pain. So if you look on the bottom of the slide, you're going to see if they have numbers 1 and 2 listed here, they have possible nociplastic pain. But if they have all the numbers, so 1, 2, 3, and 4, then they have probable nociplastic pain. So let's see, what does that look like? What are these different factors? So number one, when it comes to pain, is going to be chronic in nature. Usually the pain is going to be going on for longer than 3 months. If they have pain that's only been going on for 1 month, it is unlikely that they have nociplastic pain. The pain will be regional rather than discrete. So instead of just a little, just like, let's say, the front of the shoulder, it might be the whole trap area, shoulder, and upper arm. So a larger region. There's no evidence of nociceptive or neuropathic pain. So you've been able to rule out nociceptive and neuropathic pain. And the big keys with nociceptive and neuropathic pain, remember, are very clear, predictable patterns with your testing. So then the second category is evoked pain hypersensitivity in the region of the pain. So static or dynamic allodynia, meaning that a posture or a movement or a load that shouldn't cause pain, that isn't really, you wouldn't expect to cause pain, does cause pain. Also, heat or cold that shouldn't cause pain is causing pain. And there's a painful after sensation reported following the assessment of those things. So you test a posture, you test a movement, you test a load. They may or may not have pain during that test, but then they're going to complain of pain afterwards. So they're going to complain of these latent symptoms, pain that comes on either a little bit or a long period of time after you did the test. These are your patients, by the way. If you've ever been wondering or you've faced these patients, you test them in the clinic and it's not so bad. They seem okay. And then they call you back 1 or 2 days later saying, you hurt me, I'm in so much pain, I woke up and I couldn't move. So things like that, when you hear that kind of stuff, right, that is your latent symptom where it's like, you do all the tests and there's no, like the patterns seem consistent, everything seems fine, there's no problem. And then all of a sudden, they're in this enormous amount of pain 1 or 2 days later. You want to be thinking the potential of this nociplastic pain. They have a history of pain hypersensitivity in the region of the pain. So they're hypersensitive to touch, to pressure, to movement, or to high heat, or to cold. And finally, the presence of other comorbidities. So any one of the following. Increased sensitivity to sound, light, or odor. Sleep disturbances and frequent awakening at night. Fatigue and cognitive problems like difficulty focusing, difficulty with attention, or memory disturbances. So these are things that you may not always be asking in the clinic, but I would like to kind of encourage everybody to begin looking at these things, especially if you expect or you suspect possible nociplastic pain, because these may be involved. Okay. So again, if numbers 1 and 2 in what we just spoke about are occurring in your patient, they have possible nociplastic pain. But if they have numbers 1, 2, and then 3 and 4, it's very, very likely, it's very probable that they have nociplastic pain. So how do we treat nociplastic pain, right? That's the big question, because these are those tough patients. These are those ones that make you scratch your head and you have no idea what to do with them. The treatment does look a little bit different than what the nociceptive and neuropathic pain treatments are. So number one, they will need pain neuroscience education. Remember that their pain, the threat that is being picked up, that is keeping their pain going, is within their brain, meaning their thoughts, their emotions, the way they're seeing the world and their condition. You want to educate them on how pain works, because if they continue to have the same thoughts, emotions, and things like that, the pain will not get better. There's no amount of just exercise or hands-on therapy or ultrasound or electric stimulation that will help these patients. They need to understand what is going on. They need to change the way that their mind works to help with this. Then you're going to want to incorporate psychologically informed and acceptance and commitment therapy. Then you move on to actual physical activity, things that you will do with them in the clinic with movement. So with these patients, some of them might be too painful to actually begin moving and exercising. So think complex regional pain syndrome, right? You have that hand or wrist that is red, swollen, and so sensitive to touch that you can't do anything with that patient. What do? The first step is what's known as graded motor imagery. So again, this goes beyond what we have enough time to cover in this brief lecture, but I want to just introduce you to this so that you will then have the knowledge to then seek out this information, learn new things. So graded motor imagery is the ability to begin using your mind or retraining your mind to get ready to move. So do things like recognizing left-right, what's known as left-right discrimination, using visualization techniques or motor imagery techniques, and using mirror box therapies. So there's a lot to graded motor imagery. Again, a lot more than I am able to cover in this brief lecture, but just to be aware, that is a very important approach for anybody that has pain that is just too painful to begin moving. But once you use those approaches and allow them to begin being able to actually move, now we get into graded increase in general daily activity. You want to help them gradually do more throughout the day. So a big example would be to gradually try to introduce more steps throughout the day. Just be a little bit more active throughout the day. Then you introduce graded introduction to exercise. So this type of exercise isn't specific to a type of injury. It's not like your ankle sprain injury or your ACL rehab program. This is just a gradual reintroduction or introduction to exercise. So being able to do body weight exercises, gradual resistance exercise, or cardiovascular exercise. Cardiovascular exercise has been very, very beneficial for those with nociceptive pain. So they may need to go slower, and there's a lot of skill to being able to gradually introduce these things in people with a lot of pain. But your goal is to introduce resistance exercise and aerobic exercise gradually to these patients. And then gradually return these patients to previously fearful activities. So things that they were once scared of, you want to find a way to gradually reintroduce it to them in a way that allows them to be less scared. So it reduces their fear, which reduces the threat within their mind and allows the pain to gradually come down. All right, and then finally, very, very, very important that cannot be underemphasized are other lifestyle modifications. So nutrition and sleep. These nociplastic pain patients absolutely need to assistance with improving their nutrition and their sleep, or at least seeing whether or not they need to improve their nutrition or their sleep. So with nutrition, whole foods, minimally processed foods are what you are trying to accomplish, and improving their sleep to be more than 7 hours per night. Again, this isn't easy, but it is a priority. All right, so that is nociplastic pain. So let's put it all together. Let's summarize and finish everything up. So as we discussed, the International Association for the Study of Pain has officially announced 3 primary pain phenotypes. We have nociceptive pain, which is the threat within the body. We have neuropathic pain, where the threat is within the nerves, and nociplastic pain, where the threat is within the brain. For nociceptive pain, you treat tissues, so you reduce inflammation and you encourage tissue healing through the inflammatory, proliferation, remodeling phases. For neuropathic pain, you decompress the nerves, you desensitize the nerves, and you're improving nerve mobility. And then for nociplastic pain, you are encouraging education. You are educating the patient on what is the cause of their pain and how pain works. you are utilizing psychologically informed approaches like cognitive behavioral therapy and acceptance and commitment therapy, relaxation, mindfulness. You are gradually reintroducing movement and you're working on lifestyle factors. Okay. So practical steps to integrate these aspects. So step one, you want to enhance your assessment skills. The goal of today's lecture was to introduce you to these classifications and to encourage you to begin trying to classify these patients, because by classifying them, you will treat them much, much better. And to appropriately classify, you want to improve your assessment skills. So you want to incorporate reliable and validated assessment techniques, incorporate red flags, visual inspection, neurological testing, functional testing, mobility, strength, special tests, and psychosocial distress measures. In our manual therapy certification, we go all through examination approaches and techniques. Then you want to communicate clearly with the patient. So you're going to use analogies and metaphors to explain the pain mechanisms. So that is your pain education, and avoid stigmatizing language. So you definitely don't want to use the words like it's all in your head. If they have nociplastic pain, even though the threat is within the brain, it is not made up. It is real pain. And so you do not want to sound like you believe that they are making their pain up. Okay. Then you're going to tailor the interventions to their pain phenotypes. So for nociceptive pain, you're going to focus on inflammatory and mechanical contributors, consider phases of healing. For neuropathic pain, you're going to incorporate nerve-focused treatments. And for nociplastic pain, you're going to prioritize psychological and lifestyle-based strategies. Upon treating, you're going to collaborate with other professionals. So for complex or mixed cases, you're going to refer to or include psychologists, dietitians, pain specialists, or neurologists. And then you're going to consistently track progress. So you're going to use patient-reported outcome measures to monitor the effectiveness and adjust treatments based on patient responses and phenotype evolution. All right, so that brings us to the end of today's session. All right, so I know that we covered a lot, and we're going to open the floor up to any questions. I'm happy to answer, and I appreciate everybody's time and attention.
Okay, thank you very much, Dr. Jean. Thank you very much for the
Of course,
information.
no problem, no problem.
Right, very good. In the early morning in the US and
Yeah,
a little bit night in here, but actually
yes.
we're starting in the evening now. But yeah, still great information for us. And then this is also the newest definition of pain. So I will a little bit give some resume or conclusion to all of the participants in Bahasa. So please allow me to speak in Bahasa about
Of course.
everything. Baik, Bapak Ibu, terima kasih untuk eh, apa namanya perhatiannya ya. Tadi kita sudah dengarkan tentang adanya tiga phenotype dari pain gitu ya. Ada nociceptive, ada neuropathic, dan juga satu lagi adalah tentang nociplastic yang selama ini mungkin kita hampir tahu sebenarnya, cuman belum terjelas terlihat. Dan di sini sudah menjadi definisi yang jelas gitu ya terkait dengan apa definisi dari International Association of Pain Science gitu ya tentang nyerinya gitu ya apa saja yang dulunya kita mungkin ini ada damage tapi ternyata ada juga terkait dengan psychological gitu ya. Ada beberapa teknik yang bisa kita gunakan seperti manual terapi untuk nociceptive, kemudian dikompres the nerve ya, sarafnya dikompres untuk kondisi neuropathic. Lalu kemudian terkait dengan psychological atau nociplastic ini kita bisa lebih kepada relaxation dengan pain science education gitu ya, kasih tahu bahwa nyeri itu berasal dari sini dan begini gitu ya. Dan hal lain terkait dengan misalkan dia acceptance ya, terima dengan kondisinya dia dan juga termasuk perubahan aktivitas gitu ya, modifikasi aktivitasnya. Dan tadi sudah dijelaskan juga beberapa poin dari PowerPoint-nya nanti akan saya berikan, tapi setelah Bapak Ibu mengisi presensi yang sudah ada diberikan. Nah, sekarang untuk tidak berlama-lama karena kita sedikit terdistract sebenarnya ada kalau yang suka main bola ini ada bola juga Indonesia dan Vietnam tapi nggak apa-apa kita tetap fokus ya kita akan bertanya jawab silakan teman-teman. Eh, Jika ada pertanyaan saya akan berikan open some questions. Semuanya boleh bertanya dalam bahasa Indonesia, boleh tulis di chat, ataupun boleh juga dalam bahasa Inggris langsung jika memang ada mau raise hand. Saya persilahkan, mungkin 3 pertanyaan dulu supaya kita jangan terlalu malam. Eh, Silakan jika ada pertanyaan. Okay, so Eugene, so we are waiting for the questions. I already allowed them to maybe raise hand or talk directly to you in English,
Fantastic.
or they can write a comment in the chat box in Bahasa,
Okay.
and then I can translate to you.
That's
Right.
perfect.
All right.
Good.
So, but if there is no question, we can we can finish your session. All right.
Okay.
Okay. All right. Yeah. Actually, before this, when you present all of your slides, maybe some one of the participant asking us about the where is the definition come from, the three phenotype of the definitions. I already told that it comes from the ISP, right?
Correct. Yep.
Yeah.
So the International Association for the Study of Pain.
Yeah.
So you can look that up. It is the kind of official largest kind of body within the whole world. So it's not just
Right.
one country. It is the international. And so if you look up that International Association for the Study of Pain, you will see them speak all about this. And there's a lot of now research, the more modern recent research in the last like 2-3 years will reference these 3 pain phenotypes.
Right. Okay, so this is one question from Kasit Ivanali, one of the physiotherapists from Indonesia. So the question is it the same or similar about the psychogenic pain and nociplastic pain?
So
Right.
psychogenic pain falls within nociplastic pain. So in other words, if somebody has psychogenic pain, then yes, that is a type of nociplastic pain. It doesn't mean that all nociplastic pain is psychogenic,
Mhm.
but psychogenic pain is nociplastic. I hope
Right.
that makes sense. I know that's a bit of a, yeah. But yes, if somebody does have true psychogenic pain, that would fall under the category of nociplastic.
So yeah, so just like a nociplastic is one of the biggest category, and then the psychogenic is one of the subcategory, just like that, right?
Yeah, correct.
All right.
Correct.
Okay, thank you, Mr. Kasit. This is one of the great manual physical therapists also from Indonesia. It's my friend actually.
Nice, awesome, awesome.
Okay, okay. Is there any question again? Apakah ada pertanyaan lagi, Bapak Ibu? Silakan. Oh yeah. So I have one question that I mean the participant Maheza.
Yeah,
Please
yeah,
Maheza.
go ahead.
Yeah. Okay, you can talk.
Okay, thank you, Mr. Lucky, and good morning, maybe.
Yeah.
Good morning. Yeah,
There's
good morning. Thank you.
there's good night.
Yes, thank
Good
you.
evening.
Yeah.
Good evening. Yeah. Yeah. Okay.
So yeah, my name is Aiza, and I was hearing about these aerobic exercises to modulate the pain. Was it correct? So
So
my
yeah,
yeah.
go on. Yeah,
So my point
exercise to modulate the pain. Yep.
is there any way aerobic exercises could modulate the pain? Yeah.
So exercise in general or a type of exercise? Which one are you asking?
I think the cardiovascular exercises is
Okay, I got you.
yeah.
Yes.
Yeah.
So there has been research showing that even as low as 10 minutes of cardiovascular exercise begins to modulate pain. So there is a pain modulatory effect. The more the better, to an extent. Obviously, if it's so much that they're in more pain, that's not right. You need to actually you need to individualize for each patient. However, there has been quite a bit of research showing that steady aerobic exercise does have a pain modulatory effect, potentially due to the release of chemicals within our body, so endocannabinoids or opioids within our own body. So yes, that does have a very strong effect.
Ya, jadi ada Mr. Maheza. Jadi katanya ketika cardio exercise kita lakukan adanya pengeluaran zat-zat penenang gitu ya, istilahnya opioid effects. Ya, right. Begitu, Mr. Maheza, apakah sudah menjawab? Okay,
Yeah,
right.
sure. Thank you.
Thank you.
Yes,
Okay, we have another question. We have
Yeah.
two questions now. So there is a question from Mr. Zhu. Is that the same? Is that same or similar the nociceptive with the central sensitization?
Yeah. So central, yep. So central sensitization falls within nociplastic pain. So again, there are those like categories of different types of nociplastic. So that would be an example. If somebody has central sensitization, that's a type of nociplastic pain that would fall under nociplastic pain.
So yes,
Yep.
so it is not included to the
Does that answer the question?
Yeah, yeah. I mean, it's not same with the neurogenic or I mean the neuropathic.
So
No,
you have with what? Which one?
the sensitive central sensitization.
Yeah. So you're asking if that's the same as what? I'm sorry.
With the neuropathic. I mean, is it the same?
Neuropathic. So
No, it's not the same.
no. So
Ah,
it's not necessarily now. Somebody with neuropathic condition can develop central sensitization,
all right.
but then they're going to be a mixed category of both
Ah.
neuropathic and nociplastic.
All right.
So once they begin to have central sensitization, you want to consider them a nociplastic.
All
So
right.
all of those things that we talked about here for treatment of nociplastic, even if they have like, let's say sciatica, but it's like a chronic sciatica and they have central sensitization, you want to still include these things within the treatment as well as your typical sciatica treatments.
All right. Thank you very much. So I think
Sure.
I hope will be the next question. It will be, how does the IASP describe the influence of biophysical psychosocial factors on an individuals with pain experience?
What do you mean how to describe, like describe to a patient or to like a therapist, or what do you mean by how to describe?
I think, I don't know, it's just from Aditya. I think how the IS describe the influence of biopsychosocial factors on individual pain experience, just like that is the question.
Well, so when we have, right, so biopsychosocial in general is obviously always a part of the puzzle. That's the whole point of the three phenotypes. So this is how we describe the biopsychosocial, right? Like if we understand the pain phenotypes, we understand what impact bio versus psycho versus social has on the patient. The nociceptive and the neuropathic is a little bit more on the bio, while the nociplastic is more on the psychosocial and how they all impact one another. So that is the approach.
All right. So yeah, actually you already answered in the slides, right? So yes, the
exactly.
ISSP is describe the influence is based on the three phenotype of the pain. So it is the biopsychosocial factors of individual pain, right?
Yes, and that's the whole point. Yep.
Okay, I think we don't have any question again. So yeah, I think that's enough for the questions. And then, yeah, thank you very much, Dr. Jean. So I will be a little bit introduce you to our participant that you will be the next instructor for the therapeutic exercise prescription, right? So
yes, I'm very, very excited for that. Absolutely.
So yeah, maybe
so
we can. Yeah.
Oh, go ahead.
Okay, we will have good courses in Indonesia, maybe in October 2025, right? So, but yeah, we can arrange the schedule in the next future. So I hope you can come and then give the experience about how conduct the exercise, therapeutic exercise in the especially in the orthopedic and manual physical therapy treatment for the patients with the orthopedics or musculoskeletal conditions. So
Absolutely, yeah.
yeah,
We will absolutely cover the exercise and how to appropriately use it for each of the three phenotypes.
yes,
So how to use
nice,
exercise for nociplastic, neuropathic, and nociceptive. So we will go
nice.
through all of them.
All right.
Yes.
So any maybe it's not the last word, I think, but last wait, message to our physios in
Yeah.
Indonesia, maybe.
Yeah. Yep. Yeah. So first, I appreciate everybody's attention and taking the time to be out here today or online today to listen to this. And I hope that the information today will help to encourage you to look at these three different pain phenotypes and realize that even with those really complex, difficult patients, if you can classify them appropriately, you will have the tools to be able to treat them well. So they won't be these like difficult patients that give you a headache and you don't know what to do about. So I hope that you'll embrace this information, use it, and really help your patients get better through the process. So thank
Thank
you.
you. Thank you very much for your encouragement. Thank you. So ya, Bapak Ibu,
Yep.
terima kasih untuk perhatiannya dari Eugene tadi ya. Jadi semakin kita pahami bahwa nyeri ada 3 fenotype, silakan gunakan sesuai dengan apa yang sudah kita punya, dengan manual terapi, dengan decompress of the nerve, ataupun dengan komunikasi dan pain educations. Jadi nanti materi akan saya berikan, Bapak Ibu ya. Ditunggu. Sebentar lagi kita akan masuk ke dalam sesi selanjutnya dengan saya terkait dengan OMPT program in Indonesia. So, Dr. Jean, thank you very much for your time. So, you can continue your works or your activity in a Sunday morning. I think it will be the holiday, so you can go around and or something like that. I will continue with my presentation about the OMPT program. So thank you very much again, Jean.
Thank you very much, everyone. Yep.
All
Thank you,
right.
Lucky.
All
See you all
right.
later.
Thank you.